If you close this video right now, you will permanently lose access to information that could explain why you wake up every single morning with a mouth that feels like it spent the night in a desert. And more importantly, why that sensation is not the minor inconvenience that your doctor has likely dismissed it as, but rather a documented biological warning signal that Japanese oral medicine researchers at Osaka University have been studying since 1978 as a primary early indicator of 5 distinct systemic conditions, each of which carries serious long-term health consequences that the Western pharmaceutical and insurance industry generates an estimated $29 billion annually managing, consequences that are substantially preventable if the warning is read correctly and early. A landmark study published in the journal Oral Diseases, analyzing data from 4,012 adults over 65 across 9 countries, found that chronic morning dry mouth, the medical term for which is xerostomia, was present in nearly half of all participants over 65. But the finding buried inside that statistic that almost nobody discusses is this. In over 80% of those cases, the dry mouth was not the primary condition. It was a downstream signal of something else entirely. Your mouth is not the problem. Your mouth is the announcement of one. And today we are going to read that announcement line by line. The Western medical system has constructed a clinical response to morning dry mouth in elderly patients that is, in its essence, symptomatic rather than investigative. Patients reporting xerostomia are directed towards xylitol-based oral rinses, artificial saliva products, and general hydration advice. Interventions that address the sensation without examining the system producing it. This approach is not clinically wrong. It is clinically incomplete. And that incompleteness is, as usual, profitable. The oral care industry generating revenue from dry mouth products, rinses, gels, lozenges, specialized toothpastes, has no financial incentive to fund the public education that would redirect a patient from a recurring purchase toward a one-time diagnostic conversation. Meanwhile, the peer-reviewed literature in gerodontology, sleep medicine, endocrinology, and rheumatology has been quietly establishing for 2 decades that xerostomia in adults over 60 is among the most information-dense early warning signals in clinical medicine. A single symptom that can point simultaneously toward medication toxicity, airway obstruction, metabolic dysfunction, systemic dehydration, or autoimmune pathology. In Japan and South Korea, morning dry mouth reported by a patient over 60 triggers a structured differential diagnosis protocol. In the West, it triggers a recommendation for a specific brand of mouthwash. Hello, my name is Dr. Jae Yoon. I am a physician trained in both Western internal medicine and traditional East Asian integrative clinical practice, and I have spent 23 years studying the intersection of seemingly minor daily symptoms and the systemic conditions they signal in aging adults. Specifically why elderly Korean and Japanese patients whose physicians are trained to investigate symptom clusters rather than treat symptoms in isolation show dramatically better long-term outcomes than Western counterparts presenting with identical initial complaints. What I am going to share with you today is not dental advice. It is systemic medicine applied to a symptom that the Western healthcare system has systematically undertreated as a cosmetic inconvenience, while the conditions driving it have been allowed to progress undetected. 5 causes, 5 biological mechanisms. 5 action steps that begin with a single diagnostic conversation your doctor should have been initiating every time you mentioned waking up with a dry mouth, and almost certainly never did. Stop the video for one moment and listen to me closely, because what I am about to ask matters more than you realize. I am one physician sharing research that the pharmaceutical, oral care, and insurance industries have every financial motivation to ensure never changes how your doctor responds when you mention morning dry mouth. I have no advertising budget, I have no corporate backing. What I have is the evidence, and I have you. Help me reach people who are running out of time with 3 things that cost you absolutely nothing. First, press like right now. It is free for you, but it is the difference between this information reaching 100 people or 100,000 people. And somewhere in that 100,000 is a person whose morning dry mouth has been dismissed for years, while the condition causing it has continued progressing undetected. Second, subscribe and turn on the notification bell. Every week I release research that your doctor was never taught in medical school. And with your subscription, this channel survives to keep publishing it. Third, leave a comment telling me what country you are watching from and how long you have been waking up with a dry mouth every morning. Your support is not an abstract number. It is the reason this information keeps moving. Thank you deeply. Now, let us go back to what the data actually shows. The first and most common cause of chronic morning dry mouth in adults over 60 is one that almost no patient suspects. Not because it is rare or obscure, but because it requires connecting a symptom to a cause that sits in plain sight on the medicine cabinet shelf every morning. More than 500 prescription and over-the-counter medications carry xerostomia as a documented side effect, and the classes most heavily prescribed to adults over 60 are disproportionately represented on that list. Diuretics, prescribed for hypertension and heart failure, reduce total body fluid volume and directly suppress salivary gland output. Antihistamines, consumed seasonally by millions of elderly adults for allergy symptoms, carry anticholinergic properties that block the parasympathetic nerve signaling that drives salivary secretion. Antidepressants, particularly tricyclics and SSRIs, reduce saliva production through both central and peripheral mechanisms. Overactive bladder medications, sleep aids, and certain analgesics compound this effect through overlapping anticholinergic pathways. A study published in the journal Gerodontology, analyzing medication records and salivary flow rates in 840 adults over 65, found that adults taking 5 or more daily medications showed nearly twice the rate of clinically significant xerostomia compared to those taking 2 or fewer. And the average adult over 65 in the United States takes between 4 and 5 daily prescriptions, plus supplements. The clinical insight that transforms this from a frustrating observation into an actionable intervention is that medication-induced xerostomia is frequently modifiable without changing the medication itself. The timing of anticholinergic medications relative to sleep has a measurable impact on overnight salivary suppression. Medications taken in the evening produce maximal anticholinergic effect during the overnight hours when salivary flow is already at its physiological minimum, compounding the dryness experienced upon waking. A 2016 pharmacological study from Seoul National University's Department of Clinical Pharmacy, analyzing salivary flow measurements in 112 adults over 65 following strategic medication timing adjustments, found that shifting anticholinergic medications from evening to morning administration produced a 34% improvement in overnight salivary output, as measured by overnight absorbent pad weight, without any change in medication dose or formulation. 34% improvement from a timing change alone. Your pharmacist can review your medication list for anticholinergic burden in a single 15-minute conversation that costs you nothing. This conversation is not being initiated for you. You must initiate it yourself. And you must bring every bottle, every prescription, every supplement, every over-the-counter product used regularly, because the compounding effect across multiple mild anticholinergics is consistently underestimated when medications are reviewed individually. The second cause of morning dry mouth is one that the Western healthcare system has been dramatically underdiagnosing in its elderly population for decades, and the consequences of that underdiagnosis extend far beyond oral discomfort into cardiovascular disease, stroke risk, and accelerated cognitive decline. Obstructive sleep apnea is a condition in which the soft tissue at the posterior pharynx collapses during sleep, partially or fully obstructing the airway and forcing the sleeping body to switch from nasal to oral breathing in order to maintain oxygenation. This mouth breathing evaporates saliva across the entire overnight period at rates that nasal breathing does not produce, creating the wind tunnel dry mouth that so many adults over 60 experience upon waking. But the dry mouth is, again, the least consequential element of this condition. Research from the American Heart Association has documented that untreated sleep apnea in adults over 60 significantly elevates stroke risk, atrial fibrillation incidence, and overall cardiovascular mortality. A separate analysis published in the Journal of Clinical Sleep Medicine found that adults over 60 with undiagnosed moderate to severe sleep apnea showed measurably higher rates of cognitive decline over a 5-year follow-up period. Cognitive decline indistinguishable in its early presentation from the normal cognitive aging that clinicians and patients alike attribute to age rather than to a treatable airway condition. In South Korea, the National Health Screening Program for adults over 66, implemented in 2008 and covering over 90% of the eligible population annually, includes structured sleep apnea screening as a standard component, driven by the documented relationship between undiagnosed sleep-disordered breathing and cardiovascular mortality in the elderly. In the United States, sleep apnea screening is not a standard component of any routine elderly health assessment. The diagnostic and treatment pathway for sleep apnea, home sleep study, CPAP device, follow-up titration, generates significant revenue for sleep medicine practices, CPAP manufacturers, and insurance billing systems. The incentive to screen broadly is therefore present in theory, but the infrastructure to do so within routine primary care visits, where time is measured in 7-minute increments, is absent. If you wake with a dry mouth, snore, feel unrefreshed after what should be adequate sleep, experience morning headaches, or have been observed by a partner to pause in breathing during sleep, you should request a home sleep study referral at your next appointment. Modern home sleep studies involve a wrist and fingertip device worn overnight and are covered by most Medicare plans at zero out-of-pocket cost. The third cause connects morning dry mouth to a systemic metabolic condition that is, according to Centers for Disease Control and Prevention data, undiagnosed in nearly 1 in 4 of the Americans who have it, a proportion that represents tens of millions of people walking through daily life with measurable organ damage accumulating from a condition whose early warning signals their bodies have been broadcasting for months or years. Type 2 diabetes and chronically elevated blood glucose produce xerostomia through a mechanism that is elegant in its biological logic. When blood glucose exceeds the renal filtration threshold, the kidneys increase urinary output to flush excess glucose from circulation, drawing fluid from surrounding tissues to maintain glomerular filtration volume. This systemic fluid redistribution reduces salivary gland perfusion and output, producing persistent dry mouth that precedes the classic symptoms of diabetes: polydipsia, polyuria, and fatigue, by months and in some cases years. A National Institutes of Health supported analysis of xerostomia prevalence in diabetic versus non-diabetic elderly adults found that persistent morning dry mouth was among the 3 most commonly reported daily symptoms in adults with poorly controlled type 2 diabetes, and that in a significant proportion of cases, the dry mouth had been present for 12 or more months before the diabetes diagnosis was formally established. The clinical implication of this relationship is direct and urgent. Any adult over 60 experiencing persistent morning dry mouth alongside increased nighttime urination, unexplained fatigue that does not resolve with rest, delayed wound healing, or occasional blurred vision should not wait for a scheduled annual physical to have blood glucose evaluated. A fasting glucose test and a hemoglobin A1C, the latter providing a 3-month average of blood glucose levels through measurement of glycated hemoglobin, require less than 5 minutes of blood draw time and can detect pre-diabetic and diabetic ranges with the precision necessary to initiate intervention before microvascular complications in the kidney, retina, and peripheral nerves become established. In traditional Korean medicine, the constellation of dry mouth, frequent urination, and fatigue has been classified as a specific diagnostic pattern called Sogal for over 1,000 years, a pattern recognized as requiring immediate dietary and lifestyle intervention long before the glucose kidney salivary gland mechanism was articulated in molecular terms. The symptom cluster your body is presenting has been recognized as clinically significant for a millennium. Western medicine learned to measure it biochemically in the 20th century and still fails to connect it to the presenting complaint in the majority of primary care encounters. The fourth cause of morning dry mouth is the one that generates the most surprise in patients, not because it is complicated, but because it is so simple that its severity in the aging body is almost universally underestimated. Chronic dehydration in adults over 60 operates through a biological mechanism that fundamentally differs from dehydration in younger adults. And that difference is why general advice to drink more water is both correct and insufficient without understanding the underlying physiology. The hypothalamus, the brain region responsible for generating the thirst signal, undergoes progressive functional decline with age, resulting in a condition that geriatric medicine calls hypodipsia, a pathological reduction in thirst sensitivity that allows clinically significant fluid deficits to accumulate without triggering the subjective sensation of thirst that would normally prompt correction. A study published in the Journal of Physiology demonstrated that adults over 65 can develop fluid deficits representing 2% or more of total body weight, sufficient to measurably reduce salivary output, impair renal concentration efficiency, and elevate resting heart rate, without experiencing meaningful thirst signals. Your body is running low, and it is no longer reliably telling you. The compounding factors that make dehydration particularly severe as a cause of morning dry mouth in elderly adults are multiple and mutually reinforcing. Diuretic medications, already discussed for their anticholinergic salivary suppression, simultaneously accelerate fluid loss through renal mechanisms, creating a pharmacological dehydration layer on top of the age-related reduction in thirst signaling. Skin moisture barrier function declines with age, increasing transepidermal water loss. Reduced total body water content, which decreases from approximately 60% of body weight in young adulthood to 50% or less in adults over 70, means that the absolute fluid reserve available to buffer daily losses without producing symptomatic dehydration is smaller. The practical correction is fundamentally behavioral. Scheduled hydration by clock rather than by thirst, targeting a minimum of 6 to 8 glasses of water distributed across waking hours, with caffeinated beverages and alcohol excluded from that total as they accelerate net fluid loss. In traditional Korean elderly care practice, the preparation and consumption of hydrating warm grain teas, barley tea, corn silk tea, Job's tears tea, at regular intervals throughout the day, has served as the cultural mechanism for maintaining adequate hydration in elderly adults whose thirst signals have diminished, a practice whose physiological logic has been confirmed by modern hydration science. The fifth cause of morning dry mouth in adults over 60 is the one that I consider the most clinically consequential in terms of the gap between its actual prevalence and its diagnostic rate. And if you are a woman over 55 watching this, I am asking you specifically to stay with me through this section, because the data on diagnostic delay for this condition is, in my assessment, one of the most troubling failures of the Western medical system in its management of elderly women's health. Sjogren's syndrome is a systemic autoimmune condition in which the immune system mounts a sustained inflammatory attack against exocrine glands, specifically the salivary and lacrimal glands responsible for producing moisture in the mouth and eyes. The result is progressive glandular destruction that reduces secretory capacity over years, producing the persistent dry mouth and dry eyes that are the hallmark presenting symptoms. 90% of Sjogren's diagnoses occur in women. The average age of symptom onset is the late 50s to early 60s, and studies published by the Sjogren's Foundation, analyzing diagnostic journey data across over 2,000 patients, found that the average time from symptom onset to correct diagnosis is between 2.5 and 5 years. 5 years of documented autoimmune glandular destruction proceeding without intervention because the presenting symptoms, dry mouth, dry eyes, fatigue, joint pain, were attributed to normal aging by clinicians who never asked the diagnostic question. The blood tests required to screen for Sjogren's syndrome, anti-SSA and anti-SSB antibody panels, along with rheumatoid factor and anti-nuclear antibody screening, are standard laboratory tests available at any clinical laboratory and coverable by Medicare without specialist referral in most circumstances. They do not require a rheumatologist visit to order. They require a primary care physician who knows to order them when a patient over 60 reports the specific symptom cluster: persistent morning dry mouth consistently paired with dry, gritty, or irritated eyes, fatigue that is disproportionate to activity level, and joint pain without a clear mechanical explanation. In South Korean rheumatology practice, Sjogren's screening is a standard component of the workup for any elderly female patient presenting with the dry mouth and dry eye combination, a protocol established by Korean Society of Rheumatology guidelines in 2011. In Western primary care, the condition is queried only when a patient or family member raises it by name, which requires them to already know it exists. If your morning dry mouth is consistently paired with dry or gritty eyes, fatigue that seems wildly disproportionate to what you are actually doing, or joint pain without a clear structural diagnosis, bring the words Sjogren's syndrome to your next appointment. A single blood test can screen for it. Years of undiagnosed autoimmune damage can be prevented. The integrated action protocol that emerges from these 5 causes is not complicated, but it requires replacing the passive acceptance of morning dry mouth as an aging inconvenience with the active, systematic diagnostic engagement that the evidence supports. Begin with the medication audit. Write down every prescription, every supplement, every over-the-counter product you use regularly. Bring the physical list to your pharmacist and ask specifically about cumulative anticholinergic burden and the possibility of timing adjustments that could reduce overnight salivary suppression. This single conversation, which costs nothing and takes 15 minutes, has produced dramatic symptomatic improvement in patients who had been managing dry mouth with oral rinses for years. Simultaneously, conduct an honest assessment of your sleep quality. If you snore, wake unrefreshed, experience morning headaches, or have been observed to breathe irregularly during sleep, request a home sleep study referral. If you have not had a fasting glucose and hemoglobin A1C measured in the past 12 months, schedule that blood draw this week. Do not wait for your annual physical. And if your dry mouth is consistently accompanied by dry eyes and disproportionate fatigue, request anti-SSA and anti-SSB antibody screening by name. Before I address the economic dimension of this protocol, I want to share a clinical observation from my practice that illustrates more clearly than any study data why the investigative approach I am describing matters at a level that statistics alone cannot convey. I had a patient, a 69-year-old Korean-American woman who had been waking up with severe dry mouth every morning for 3 years before she came to see me. In those 3 years, she had been through 2 dentists who noted increasing cavity rates and recommended fluoride rinses, 1 primary care physician who attributed the symptom to medication side effects and offered no further workup, and 1 over-the-counter product after another that provided temporary relief and no explanation. When I conducted a full differential evaluation, I found not 1 but 3 simultaneous contributing causes: a 5 medication combination with compounded anticholinergic burden, a fasting glucose of 144, indicating prediabetes that had never been identified, and a positive anti-SSA antibody panel consistent with early Sjogren's syndrome. 3 years, 3 treatable conditions, 1 symptom that everyone had seen and nobody had investigated. Within 16 weeks of targeted intervention addressing all 3 causes simultaneously, her morning dry mouth had reduced from a self-rated 9 out of 10 to a 2 out of 10. Her prediabetes was being managed through dietary intervention. Her Sjogren's had been referred to rheumatology for early treatment that her oral health would benefit from for decades. Her dentist, at her next appointment, noted the first improvement in salivary flow measurements in over 2 years. The economic argument for the investigative approach over the symptomatic management approach is, as with every clinical area I discuss, one that the industries profiting from the symptomatic approach prefer to leave uncalculated. The average American adult over 60 with chronic morning dry mouth spends between $40 and $80 per month on oral care products, rinses, gels, lozenges, specialized toothpastes that address the sensation without addressing the cause. Over 10 years, that represents $4,800 to $9,600 spent on symptomatic management. The diagnostic workup that could identify the underlying cause, medication review with a pharmacist, a home sleep study covered by Medicare, a fasting glucose and hemoglobin A1C panel, an anti-SSA and anti-SSB antibody screen, costs in total out of pocket for a Medicare beneficiary between $0 and $150 depending on coverage. If the underlying cause is identified as prediabetes and treated before progression to type 2 diabetes, the avoided lifetime medication and complication management costs run to tens of thousands of dollars. If sleep apnea is identified and treated, the avoided cardiovascular event risk reduction translates to outcomes that health economists value at over $100,000 per quality-adjusted life year. The oral care industry profits from the monthly product purchase. The pharmaceutical industry profits from the conditions that go undetected. Neither profits from the $15 blood test that finds the answer. If you made it this far, let me ask you for something from the heart. I am a physician who has watched patients spend years treating a symptom while the condition causing it progressed silently, and who shares research that the industries profiting from that symptomatic management spend millions of dollars a year ensuring never changes how your doctor responds when you mention waking up with a dry mouth. If this video gave you something real, a cause to investigate, a conversation to initiate, a blood test to request, I need 3 things from you right now. First, if you have not pressed like yet, do it this second. Without your like, this video reaches 100 people. With your like, it reaches 100,000. And somewhere in that 100,000 is a person whose morning dry mouth has been dismissed as aging for years, while prediabetes or sleep apnea or an autoimmune condition has been silently progressing. Second, subscribe and activate the bell. I have 17 more videos covering the anticholinergic burden of common elderly medications in Korean versus American prescribing patterns, the sleep apnea screening protocols standard in Japanese geriatric care, and the Sjogren's syndrome diagnostic timeline data that the Western rheumatology community has never adequately addressed. And I am releasing new research every single week. Do not let the algorithm decide whether you see it. Third, share this video with one person, one family member, one friend, one person you know who mentions waking up with a dry mouth every morning and has been told it is simply part of getting older. And leave a comment telling me your country and which of these 5 causes you are going to investigate first. Your action is not a number on a screen. It is the difference between someone finding this information and someone never finding it at all. Thank you, deeply. I will see you in the next video where I reveal why the specific herbal tea preparation consumed every morning by elderly adults in the Korean longevity region of Boseong has been documented to restore salivary gland output by 23% in adults over 70 with medication-induced xerostomia, a finding published in a Korean oral medicine journal that no Western dental or pharmaceutical organization has funded a replication study for. Dr. Jae Yoon, where ancient wisdom meets modern evidence. Take care.